Good day, everybody. This is Martin Grobusch speaking. I'm a professor of tropical medicine and travel medicine at the Amsterdam University Medical Centers, University of Amsterdam, the Netherlands. And I'm wearing a couple of other hats, such as being a visiting professor, both at the Institute for Tropical Medicine at the University of Tübingen in Germany, the Institute of Infectious Diseases and Molecular Medicine, University of Cape Town, South Africa. And I'm a work group leader of clinical medicine at SAMEL in Lambaréné, Gabon, and director of the Masanga Medical Research Unit in Masanga, Sierra Leone. My topic today is sepsis triggers tropical infection. Now, what does this title imply? Firstly, it says that some pathogens which we either encounter exclusively in tropical and subtropical areas of the world can cause a sepsis-like picture, or can cause sepsis, actually, or can trigger sepsis. And if we look at the worldwide map, I showed that in a other talk before that, where Hindonda and other colleagues in a sepsis management textbooks depicted the most relevant infectious diseases as per global burden of disease study. We can see that if we look at pathogens prevailing in the various world regions, that in almost every world region we encounter pathogens which are able to trigger sepsis, actually in terms of bacteria and fungi, are maybe with some regional differences ubiquitously occurring worldwide and causing a very similar clinical picture wherever we encounter them in terms of real sepsis. But what we also see is that in most of the world regions, we see other diseases such as tuberculosis, which we in the first place don't necessarily link to sepsis, but as I alluded to in another talk already, they might cause either a sepsis-like picture or even sepsis itself. And then there's, of course, in the tropical and subtropical regions of the world and in sub-Saharan Africa, still in particular, malaria, which accounts for a vast majority, or at least half of all cases of febrile conditions. And in its extreme form, when it becomes severe malaria, it leads even to a sepsis-like picture. And as well, and that's also interesting, malaria can trigger sepsis, so pave the way, like many other pathogens, for bacteria to invade and then cause a true sepsis. And then, of course, in Southeast Asia, in the greater Mekong area and beyond, dengue as the principal arboviral disease worldwide in tropical and subtropical regions, but in particular in Southeast Asia, can also cause a sepsis-like picture. And I've shown this slide before, where we look into one particular aspect of therapy for diseases which present sepsis-like or which causes sepsis, and this aspect in this case would be fluid therapy. And with the example of bacterial sepsis versus severe falciparum malaria versus severe dengue, we've made the case that it's really, really important that we understand which underlying pathogen causes this sepsis-like picture, because that has implications on clinical care. So let us look in due course very briefly at a selection of important diseases to consider across tropical regions, actually. And tropical, really, we have to understand that in a broader context. It's tropical, subtropical regions, and some of these pathogens I'm alluding to, like malaria, dengue, or in an extreme form, Ebola, as one of the hemorrhagic fevers, actually are really specific to certain areas which we dub the tropics and subtropics. But there are others, and in particular on our list here, typhoid fever, leptospirosis, tuberculosis, which are not really confined to tropical and subtropical settings, but which are encountered in tropical and subtropical settings, and to some extent might lead to presentations, have clinical implications which differ in that geographic area from others. Let's briefly look at malaria, actually the principal tropical disease, if we may say so. Malaria epidemiology has changed over the past 2 decades. There was a huge rollback on malaria, and probably the biggest trigger to consider or to realize that there were far fewer malaria cases than always assumed was that when WHO introduced its policy that nobody should be treated for malaria unless diagnosed at least with a rapid diagnostic test before. That was a major factor which led to almost halving our estimates of malaria cases. So we still see, and then over the past 1.5 decades, 2 decades actually, major efforts in malaria control have been made, clamping down on mosquito vectors wherever possible, treating people consequently with the best possible available therapies, which is across species, but in particular for severe malaria, artemisinin combination therapies. But still, malaria is and prevails as a major problem. We see still hundreds of thousands of lives lost, particularly in young children under 5 and pregnant women, mainly in sub-Saharan Africa due to falciparum malaria. There is another region of concern still, which is the, greater Mekong area in Asia, in Southeast Asia, where resistance is usually starting to spread from. However, in the Mekong malaria area, we now encounter only 20 to 30,000 cases per year. So we are getting much closer to elimination, if not even eradication, than we are in sub-Saharan Africa. And then, of course, there are the species which also account for a large number of cases, Vivax malaria in particular, which usually do not lead to a life-threatening picture, but of course, this can also happen under certain circumstances. But severe falciparum malaria is what presents like a sepsis-like picture, actually. And malaria can also pave the way for a classical bacterial sepsis. Malaria parasites clog up, falciparum parasites clog up the capillaries and lead to membrane disruptions. Also in the gut, particular non-typhoidal salmonella can invade the bloodstream, and in particular in Southeast Asia, but to a certain extent also in sub-Saharan Africa. And as we can see also in severe imported cases outside endemic areas, this may give rise to an NTS sepsis, actually. Malaria, the most important thing here is, like with sepsis, I say, is to recognize the pathogen quite early in the course of the disease. If we are timely, and I would determine a rough time window of 2 to 3 days, then we can treat almost all cases of severe malaria before they even grow out into a life-threatening problem rather effectively with IV artesunates. If the cases are still milder, we might use oral therapies. Watch out for bacterial complications. We can see that actually in a rather simple way. If a malaria patient does not drop in parasite counts very, very effectively and very quickly after 2 to 3 days, if the white blood cell count starts climbing up, then we need to be very, very alert. This is probably not a case of resistance, but that is probably a case of bacterial complication of malaria. And to that end, malaria cannot only lead to a sepsis-like picture, but also pave way for classical bacterial sepsis. So early treatment, early diagnosis and treatment is key. And this is also where ends meet. This is very much what also formed the principle of any sort of sepsis recognition and successful treatment. Now, the other big tropical disease is dengue, the most proliferative arboviral infections worldwide encountered. As you all know, dengue might lead to complications, particularly in people who undergo or who experience a second or a third infection. The pathophysiology is complex. We would leave it to that at the moment, that most severe cases are encountered with secondary and tertiary care cases. And severity in that case means that we do have a capillary leak syndrome in combination with a interaction with thrombocyte generation and function. So in a uncomplicated dengue case, we'll have a biphasic fever, very often accompanied with rash. Patients do feel very, very ill, but most patients with adequate fluid support and symptomatic treatment will recover quickly. However, there are complications, dengue shock syndrome basically in the young under 5s, and dengue hemorrhagic fever, hemorrhagic manifestation with a volume depletion shock in adults. Now, we don't have any specific treatment so far. Increasingly so, with the second vaccine just having been registered and being soon about to be marketed. We do have prophylactic tools, but here, most importantly, once somebody has gotten dengue, the backbone of the therapy is still aggressive fluid resuscitation, being very much alert for bleeding complications, watching the thrombocyte count, and if need be, then and wherever possible and feasible, thrombocyte replacement, actually replenishment. These are the backbones for therapy. And of course, like with any severe illness, true sepsis might arise as a complication as well. Now, another disease or group of disease, the viral fevers, hemorrhagic fevers, as we still call them, although only a majority of patients experiences classical bleeding, even in the end stage of the disease, is for sure also a matter of concern. If we put Ebola in perspective with other causes of very, very severe illness, which either mimics sepsis or also in the case of Ebola might pave the way for bacterial and fungal complications, thus giving way to true sepsis. Actually, the point with Ebola is that although across all epidemics which we have encountered worldwide since the pathogen was identified for the first time almost simultaneously in 1976 in Uganda and in the now Democratic Republic of Congo, actually no more than about 45,000 people ever developed Ebola. Now, this sounds stunningly little, actually, if we compare it to the hundreds of thousands of people suffering from malaria each year, if we compare it to the enormous numbers of patients developing true sepsis. But the problem with Ebola, like with many other of the, or some other of the viral hemorrhagic fevers, is that they impact so massively, as we can see here depicted in a small rural hospital in Sierra Leone, where I worked during the outbreak, that all the usual services really collapse, and that it takes a lot of effort to rebuild these structures, actually, in order to account for all the other diseases which do not simply go away when Ebola hits. Now, in terms of pathophysiology, the Ebola virus is extremely contagious and infectious, actually, with its glycoprotein spikes. The Ebola virus has an enormous capacity to moor and fuse with almost any human cellular membrane, actually, which means the virus can easily replicate within a human after contact with any human bodily fluid. This is the other characteristic. We find Ebola in semen, we find it in salivary. In saliva, we find it in even lacrimal fluid and in sweat, which is the reason why it's so extremely contagious. Now, identifying an Ebola case is very, very important, but because we want to limit exposure to bodily fluids in those suspects, we violate two basic infectious diseases management rules deliberately when it comes to identifying and caring for Ebola patients. Bacterial sepsis and malaria are the most important differential diagnosis in somebody presenting with Ebola-like symptoms. Although we have to take into account that, of course, an Ebola patient might also have malaria. And of course, Ebola itself, with the massive destruction of membrane breaches in the body, paves its way to bacterial sepsis as well. But the two principles we use in early recognition and management of Ebola suspect patients is, apart from aggressive fluid resuscitation, is that we treat blindly, so to say, with broad spectrum antibiotics and with antimalarials. And that reduces very, very drastically, even before we are able to confirm a diagnosis, the number of suspect cases, because all the malaria and early bacterial sepsis cases are treated rather effectively, even without a proper diagnosis. And these therapeutic principles, which, as I said, differ completely from what we usually do, where we are always striving in the first place for at least sampling materials actually to establish alternative diagnosis. This leads in the end phase, interim and end phase of any Ebola outbreak to a rapid turn of the tide against the disease, and that helps us to get outbreaks efficiently under control. There is specific treatment. There are specific treatments, at least for the Zaire Ebola virus, which caused, for example, most outbreaks in Central Africa, where the disease is at home or the pathogen is at home. And during the last West African outbreak, unfortunately, as we see, monoclonal antibodies and also the vaccines, which we have up our sleeves now, are less effective against the strain which is responsible for the current Uganda outbreak. But this is for sure about to change. Monoclonal antibody therapy, actually, which is, of course, not to be preferred over vaccination of contacts during the incubation period. But if need be, once a patient is infected, monoclonal antibodies work well, but there are many problems, logistical problems, manufacturer problems, cost problems, which render them impossible solutions on a broad scale for turning the tide during an outbreak. So early recognition, broad spectrum antibiotics, malaria treatment are the backbone of our strategy to assist patients to be removed from the list of suspects. And it's also beneficial for those who in the end do have Ebola in order to help them survive. Now, two other diseases, very important. The one is not really a tropical disease, actually. Typhoid fever, bacterial disease, which is rather not a gastrointestinal disease, but a systemic disease. Actually, it's transmitted through contaminated water or foodstuffs, usually in small outbreaks. As I said, certainly not confined to the tropics, but most prominently in those encountered in those areas in the world where hygiene circumstances are difficult. Actually, the bacteria translocate through the gut. Actually, they replicate in lymphatic tissues of the gut, the so-called Peyer's plaques, which in the extreme can lead to perforation and very often then death if patients are not rescued with an emergency laparotomy. Actually, the bacteria cause a wide range of diseases. It's a diagnostic chameleon to many ends. There are typical signs such as roseolae on the skin, the infamous bradycardia, whilst people do have high fever. Actually, they are all not specific, of course, and with typhoid, high suspicion is needed to recognize patients early, and early anti-bacterial chemotherapy is the clue to the key to successful treatment, again, as early as possible. And this is a true sepsis-like disease in any case, and matter-of-factly, it can be effectively treated if recognized early. So not to be mistaken with typhoid fever as typhus, rickettsial diseases. In the English language, typhus is not mixed up with typhoid fever. Everybody knows these are two distinct diseases. For those not from an English-speaking background, this might be confusing because, for example, in the German or Dutch language, as well as in others, typhus would be what we call a typhoid fever, whereas typhus is really a rickettsial disease. Those are regional diseases. They are transmitted by vectors, ticks, wide variety of ticks. Also other vectors, actually, many of them come with typical lesions such as a primary port of entry and eschar on the skin. Others don't. On light skins, we can see typical skin changes, small spots all over the skin, whereas this is very difficult to recognize on dark skin. Also, not all of these rickettsial diseases which can manifest as a sepsis-like picture, actually in a sepsis-like picture, can be easily recognized, and sometimes these typical features are also even absent. And in some patient cohorts, such as those which we encounter here at the University of Amsterdam in returning travelers, rickettsial diseases, whether it's Rickettsia chuchukamushi or Orientia or the African typhus causes such as Rickettsia conori and africae, they are accountable for quite a number of cases, actually. And as a rule of thumb, we have identified that if we are unable to identify a causative agent of a sepsis-like picture within 24 to 48 hours, it's to a certain proportion rickettsial diseases which are behind that. And the nice thing about rickettsial diseases is that at least in the early stage, they can be easily treated with a very inexpensive drug, doxycycline, twice 100 milligram per day. And patients who are apparently very, very ill will recover rather quickly. The other very often underdiagnosed, or at least not initially suspected, cause of a severe disease is a real and true diagnostic chameleon. Leptospirosis occurs worldwide, and of course, wherever there is freshwater contact, wherever man might have contact with contaminated freshwater, where rats and other rodents would have urinated into the water, very, very few organisms are enough to cause a range of symptoms that might be classical Weil's disease with icterus and renal failure, but like here seen in a young man who returned from travels to the tropics, almost asymptomatic on first patient contacts, and then within hours deteriorating with an almost white lung due to pulmonary hemorrhage. That is the other spectrum of the disease, a wide range of possible manifestations, a wide range of clinical signs and symptoms. If early recognized, very easy to treat and good to treat, but if missed in the first instance, then a sepsis-like picture will ensue with a high mortality. And last but not least, of course, this is only a selection of pathogens, a slide which I have already presented in another talk, actually. Even pathogens which we do not primarily associate with sepsis or sepsis-like picture, in this case, tuberculosis, can also contribute to a lot of pathology in unusual ways. So as with every other pathogen, actually, and maybe irrespective of which pathogen is responsible in the end, actually a high index of suspicion that a disease, whatever it is, develops into sepsis, triggers sepsis, or becomes sepsis in the end stage of the disease, is what will save the lives of our patients, irrespective of whether it's a high-end, affluent setting or a setting where we have to deal with more basic health facilities in low and middle income countries. The key to survival of our patients is early recognition and a high index of suspicion. And with this, I would like to end already, and I thank you very much for your attention. Thank you very much, and have a good day.